And I was thinking, are other women going through this? They must be, right? Because this is normal. This is normal. I normalize it in my head.
And no questions, no explanation. I just knew this was further proof to keep my body and what was happening to it hidden.
Now, did this whole experience of not having control over my bowels, or even the fact that I honestly hadn't had a period for 3 years leading up to the New York Marathon, create any kind of sense of warning within me?
So what's more orderly than a menstrual cycle, a period? It comes every 28 days. It doesn't discriminate. Doesn't matter what your religion is, your race, your ethnicity, or what your income is.
And whatever the it was, I knew was big. And my questions were met with unhelpful answers along the lines of, "You'll understand all of it soon enough. No need to hurry anything."
I was amazed that a disorder this prevalent and connected to so many chronic and life-threatening disorders was relatively unknown and going under the radar.
Hi, I'm Beth Battolino, CEO of Healthy Women, and I am thrilled to welcome you to today's Understanding Your Period webinar. For more than 30 years, millions of women have turned to Healthy Women for answers to their most important and most personal healthcare questions, including menstrual health. And if you do not think people are talking about periods, let me share that this past week, a holiday week, we had almost 12,000 page views on an article that talked about our menstrual cycle. Periods are taboo for far too many people, and it's critical that we elevate and normalize the discussion, which is why today's conversation is so important. And we will continue to pave the way in destigmatizing and empowering women to talk about their periods. I would like to thank Myovant Sciences for helping bring this important series to life. And now I'd like to introduce today's moderator, Missy Lavender. Missy Lavender is a colleague and a dear friend. She is also the founder and CEO of Renalis, a company developing digital therapeutics for pelvic health disorders. Missy is an internationally recognized author, speaker, innovator, and champion for patient-centered care in pelvic health. We are so excited to have you here, Missy. And now I'll turn the program over to you.
Thank you, Beth, and welcome everyone. I'm Missy Lavender, as Beth just said, and I'm delighted to moderate today's webinar, Understanding Your Period, What's Normal and What's Not. I'm thankful that you've joined us for what I know will be an informative, engaging conversation on this very important topic, and it's my honor to introduce today's panelists. First of all, I'll meet Patty Garrity. Patty is a nurse practitioner with over 20 years in women's health. She's director of women's health in a multidisciplinary practice in Walnut Creek, California. Patty speaks and publishes nationally on topics pertinent to women's health. She's a member of the Medical Advisory for Sharecare, Inc., and is a member of the North American Menopause Society, NAMS, a member of Nurse Practitioners in Women's Health, and the American Academy of Nurse Practitioners. Welcome, Patty. Next, I'd like to welcome Nakem Oshan. Nakem is a public health analyst with the U.S. Department of Health and Human Services, where she provides support and technical assistance to rural communities with the goal of improving access to care, service delivery, and health outcomes. She's also a patient advocate and serves as the director of medical partnerships with the White Dress Project, an organization focused on raising awareness about uterine fibroids. Nakem struggles with fibroids and shares her story to help break down the walls of silence around this common gynecological condition. Welcome, Nakem. And then I'd like to introduce Laura Strassfeld. Laura is the co-founder and executive director of Period Equity, a national law and policy nonprofit fighting for safe, sustainable, tax-free menstrual products that are free to everyone who needs them. She initiated a 2016 class action suit challenging New York's high sales tax on menstrual products as unconstitutional, which led to immediate legislative repeal. And in 2019, she launched the tax-free period legal campaign. I'm sure you'll correct me on that, Laura, to challenge the 30 remaining tampon taxing states to do the same. Thank you all for joining us today. Really excited about this talk. So I think we probably need to start, Patty, with the basics. So let's define menstruation if we could, and the basics about having a period, maybe the average length, the average age a young person starts with their period in the United States. Can we do that first?
Thank you. I'm thrilled to be here today, Missy, and everyone else. Normal periods, that's a great question, because many of us are taught they come every 28 days and they last 5 days and that's all there is to it. But in fact, there's a great deal of normal variability. So a normal period can come anywhere between 24 and 37 days apart and can last up to 8 days. Less than 2 days, more than 8 days, too short, too long. Outside, those are the things we're going to concentrate on today. Young girls start their periods around 12 years old, could be as young as 10, could be as old, but should be started by age 15, 16. And then periods end, the average age is about 51 years, but I look forward to talking about the things that happen before that average age of 51 years during today's discussion.
Right, so much to talk about. So, Kim, can we just touch on briefly the differences in the African American community around periods?
Yeah, so when it comes to fibroids, for example, African American women are more likely to get fibroids at younger ages. They're more likely to experience heavier menstrual bleeding. They're more likely to get a blood transfusion as a result. They're more likely to be hospitalized as a result. Although 70% of white women will be diagnosed with fibroids by the age of 50, that number is higher for African American women, which rises to 80%. So there's a disproportionate burden on African American women as opposed to white women when it comes to fibroids and menstruation that goes with that.
Got it. So, Patty, let me back to you for a minute. So, let's talk about normal versus abnormal bleeding, because it feeds right off of what Kim was just saying. So, what's considered normal and abnormal?
Absolutely. A lot of women normalize abnormal bleeding and fail to seek care about it. But we look at duration of bleeding, we look at frequency of bleeding, and then we look at how heavy. How heavy is pretty simple. If it's messing with your life, it's too heavy. So if it's interfering with your quality of life, your ability to do your everyday activities, seek care. It's too heavy. How long is too long? If you're going more than 8 days, that's too long. But if you have a very regular pattern, you're 4.5 days, and all of a sudden it starts changing, another reason to have a discussion with a clinician about it. The opposite of that also, if you're spotting bleeding between periods, get an explanation for what's going on.
Perfect, thank you. And I'm going to step back for just a second because our last panelist was able to join us. So I want to welcome Dr. Jessica Shepherd. Jessica is a board-certified OBGYN and the Chief Medical Officer for Verywell Health. She's the founder and CEO of Sanctum Med Plus Wellness, a wellness concierge practice, and is affiliated with Baylor University Medical Center in Dallas, Texas. Dr. Shepherd's passion for women's health, from minority health disparities to reproductive justice, has led her to speak as a keynote speaker and participate as a moderator and panelist at so many conferences. Dr. Shepherd is also a member of Healthy Women's Advisory Council. Welcome, Jessica.
Hi, Missy. How are you?
I'm well, thank you. So since you're here, let me just follow that Patty's comment there about lifestyle factors. So what type of lifestyle factors or behaviors might affect your period?
Absolutely. We know that when it comes to lifestyle factors outside of things that we can't control, such as genetics, again, Kim was discussing fibroids. Now, those are things that you might see more in African-American adolescents and young women. The things that we can control and impact our cycles are, again, things such as obesity. The foods that we eat, more inflammatory foods, are going to be the ones that possibly incite cycles that are maybe heavier or longer in duration. And then also, again, exercise. Exercise is a key part of lifestyle factors that can help with pain with periods, for example. So the more that we exercise, we're going to increase those endorphins and then decrease kind of the pain that you might feel or sense during a cycle. And then also, again, things that you can eat kind of a little bit closer towards your cycle, which might impact, again, the cycle in intensity or its flow, or the pain perspective might be foods that are more salty. Everyone always usually loves to maybe eat chocolate or sugary foods close to their cycle. And then also alcohol. So when we look at lifestyle factors, there are so many things that we can do to, again, tailor how our cycles are, but also the therapies that we might get from a physician or a healthcare provider that can, again, add on into how that can complement the medications and procedures or surgeries that might be recommended by a healthcare provider.
Great. Well, I love knowing that chocolate and salty go with your cycle, because that says it all.
Well, they shouldn't eat those.
Why crave them? So, Patty, you mentioned it earlier, but why does your cycle evolve as you age? What are some of the changes maybe to expect as you're moving into perimenopause?
Well, definitely everything about us is designed to keep those eggs going, to keep functioning. We're designed to reproduce. That's part of the human animal nature that we are. And so as we're getting into what is called the late reproductive stage, this isn't menopause yet. You're still maybe in your late 30s, your 40s. The volume of eggs, the population is decreasing in your ovaries, but other hormones are also going down. Your inhibin is going down. Your AMH is going up. So it's programmed to say, even though there aren't many eggs to call upon, we're going to make the best hormonal environment possible to keep the eggs going. So we can have much higher estrogen right before we go into the official perimenopause stage. And that can lead to very heavy periods. My patients sometimes call them crime scene periods, where you are changing maybe for a day or 8 hours, you're changing your protection every 1 to 2 hours, and then it slows down. And so it doesn't really fit the parameters of more than 7 days variability in your period, but it is something that we need to let women know can happen and how to deal with that.
Well, let me just follow it up with a question we got from the audience before the panel started. The question was, should I be worried that I've had a couple of clots larger than a quarter over the past year, or only if I have frequently recurring large clots? So Patty, Jessica, feel free to jump in, raise your hand, raise your finger.
So what we're trying to distinguish is dangerous bleeding from really nasty bleeding. And if you're having clot after clot and it's lasting more than 2 hours, that would be accessing emergency care. But if you're having, and large clots, we're talking plum-sized. If you're having a clot and then it tapers down fairly quickly, then it's access care, but it doesn't need to be an emergent. Jessica, I'm interested to hear what you have to add.
Yeah, one of the things is bleeding in frequency, and again, the amount that we bleed during cycles. Now, everyone is going to have a different flow, and it's right to categorize what that might look like on a normal basis. And some people are heavier bleeders rather. And so, looking at the size of clot, I usually like to equate it to fruit size, like a grape, a small little maybe tangerine, and then going up into your larger clots, which might be like an apple or even a plum size. Now, when you start to have, a person might have a clot that is relatively large, but it might be the only one and not continuing to see those clots. Now, the real thing with bleeding and how heavy it is in clots is not so much if you're having clots, it's how big are they and how continuous are they. And so, as Beth was saying earlier, if you see clots that are larger in size and are continuing, that's when we really start to worry, is this now impacting your hemoglobin and causing you to be anemic per se? Now, this is why it's so important to have these discussions early on with your healthcare provider to make sure that we're trending this type of bleeding, because if it is continuing over a certain amount of cycles, we really need to monitor that and then decide, what we should do in order to decrease that, or to figure out what the issue is, whether that's from a polyp, a fibroid issue, or even hormonal issues of why you can have heavy clotting. So again, it's trending it, making sure that we're having healthy conversations, and then also finding the source of the issue in order to fix it.
Got it. Thank you for asking. I had a question about iron deficiency, so you just answered that. So Laura, can I go to you for a minute? So why is there stigma, do you think, around talking about menstruation periods?
I love that question, because as I'm listening to all of you speak, I'm reminded of my childhood, which was with an OBGYN dad who during dinner, and this was, before cordless phones, would walk a few feet away from the dinner table and take a call from a patient and ask her, how many pads are you bleeding through? How often are you changing? So I was exposed at a very young age to very frank, even clinical, medical conversations about menstruation. I have no problem talking about menstruation, but I'm, regularly reminded that this is not something that other people grew up speaking about, frankly, and many times quite the opposite. And so stigma is very real, as I've seen, and I'm alluding to ways to alleviate, even eradicate it, by just speaking very early to young people and very frankly about menstruation.
Great. Nakem, let me ask you the same question, if you would. What do you think is the stigma, or why we have stigma around menstruation? Thank you for, we should have a pronunciation, menstruation. I always kind of zip through that last syllable. So turn over to you.
Yeah, so I am actually Nigerian American. I have the completely opposite experience. In Nigeria, it is completely taboo to talk about periods, to talk about menstruation. You're considered unladylike if you talk about something so private, so publicly. And the same thing with the reproductive health issues that are associated with menstruation, like fibroids, like endometriosis. There's so many myths and misconceptions about those reproductive health issues. Some of the primary misconceptions are you're automatically viewed as infertile, barren, you can't have kids. And then you're viewed as undesirable for marriage as a result of that. So we are taught not to talk about that publicly. It's private. You do not talk about it publicly. And that is where therein lies the problem. So many women are suffering in silence as a result of this, which is why conversations like this are so important to have, to change the narrative around it, to demystify the myths, and to shatter the stigma that keep us all suffering in silence with this with conditions of reproductive health and menstruation.
Thank you. So let me just pick that up. So Patty, what kind of cultural differences we've just heard a couple, do you see leading to either misdiagnoses or delayed diagnoses? And then Jessica, I want you to comment.
I'm bilingual, and so a lot of my patients are monolingual Spanish speaking. I'm not Latina myself, but I see very similar culture to what Enkem was speaking about in Nigeria. In the Latina population, it's private. It's not something you might talk with girlfriends about it, but you don't talk about it perhaps even with your own mother, who may or may not be able to give you advice. So I will have women that I see in the clinic that may have had extremely heavy bleeding and their hemoglobin is down around 6 or 7, and they've lived like this for years. I have women that come in 41, 42 years old and haven't had a period in 5 or 6 years. And with erratic access to care and a cultural taboo about asking about this, it takes a lot of courage for those women to bring it up in the clinic and say, this is what is happening to me. It's a privilege to work with this population.
Thank you. A little bit of a computer snafu there, so apologize for going off. Jessica, were you able to comment yet?
Yeah, just going into what everyone has spoken already, talking about what Patty is seeing in the Latina population, and Kim from her personal experience as a Nigerian American, is that a lot of this is founded in what socially women are supposed to believe or behave or act, what's appropriate. And that comes from a long-standing foundation of somewhat patriarchy, or, as far as women, what they're allowed to express from their sexuality or their reproductive systems has always been, one, for the most part, and even somewhat here in America, is something that we should be, and I like to say below the belt, that's something that you, Missy, are very familiar with. That term is that when it's below the belt, it becomes very shameful, and then is always a lot of times directed towards fertility and the ability to do that and what might come. And so there's a lot of miscommunication and myths that have, generated over generations, and that's what we call generational storytelling, in the sense that these are things that are passed down along generations, and therefore that becomes the norm. And so it really takes conversations such as these to be able to disrupt myths, to really look at education and educating through resources and proper education, so that we can, again, use this information not only to empower women, but in order to disrupt that communication that we've seen throughout generations, so that we can get to a point where we're really impacting the quality of life of women, which is what we're trying to do with this conversation today.
Definitely. So I want to go back just to Nakem, if you could tell us a little bit about your journey, because I don't think what you've experienced around misdiagnoses is necessarily, I think it's very common. So if you wouldn't mind sharing that with us, that'd be great.
Sure. So my health journey when it comes to fibroids started in 2015. It seemed like my period changed drastically. Like, it seemed like it changed overnight. I was literally changing my pads every 30 minutes. I would have really heavy clots the size of my fist frequently, painful. My periods would last 2 weeks or longer. I would bleed in between periods. It got to a point where I couldn't walk 2 steps without feeling like I was going to pass out. I would have humiliating experiences of bleeding through my clothing in public, on several different occasions. But even with all of that, I normalized it because, my mother had heavy bleeding, my aunts had heavy bleeding. So I just chalked it up to, this is my plight in life. This is what I'm meant to go through when it comes to periods, but it got to a point where I really could not walk without feeling like I'm fighting for air with every step that I took. And my sister, who happens to be a doctor, she came into town. We went to church one day, and I soiled my clothing and I soiled the seat. And she asked me, how long has this been going on? And I told her I've been having really heavy menstrual bleeding for the past several months. And for the past few weeks, I've been feeling really weak. So she asked to look at the palms of my hands, the inside of my eyes, and the inside of my mouth. And she said, you literally look like you have no blood left in your body, and you need to make an appointment to get some blood work done ASAP. So it was at her urging that I made the doctor's appointment, got the blood work done. My doctor called me back. She said, you need to go to the emergency room right now because your hemoglobin is dangerously low. It's at a 3, and that is not conducive to life. So those words, not conducive to life, really struck me because I equated that with death. So I went to the emergency room. They ran a host of tests, including an echocardiogram, because I also had a lingering cough that would not go away. And they discovered that I developed something called cardiomegaly, which is an enlarged heart, because like my sister said, I literally had no blood left in my body, and my heart was working in overdrive to compensate for that lack of blood. So I needed a blood transfusion because I could have gone into cardiac arrest at any moment. And of course, they attributed all of this at the time to one large fibroid that was on the surface of my uterus. And I didn't know what fibroids were. I knew my mother had them. We didn't talk about it. It was when I was diagnosed, that's when my mother decided to have the conversation with me about what fibroids were.
And how old were you at the time?
I was actually 29 when I was first diagnosed.
Got it. Okay, let's just pick up on that theme. So, Jessica, let's define fibroids for the audience, please.
Yeah, fibroids, much on what Kim is discussing with her journey, is that many times women don't know that they have fibroids. And when they hear that they have fibroids, they are very unsettled. It's news that they find kind of defeating in a way. And, the way I like to approach it is to allow women to understand that it is something that is very common. Not so much that it's common that I just want them to take that message and be like, this is your diagnosis and that's it. But for them to know that they're not alone in the journey. And many women feel that they are. So fibroids are actually the most common benign, they're not cancerous, the most common benign tumor of the pelvis. And really what it is a smooth cell muscle fibroid or a tumor that rapidly grows. Rapidly grows in the sense that it grows slowly over time, but with the growth of a fibroid, it can get anywhere to the size of, sometimes I've seen maybe a small watermelon. And so because it grows slowly over time, I like to call it the new normal, is that women may not notice the change significantly because it's over time. And what they will notice more so are the symptoms. And the symptoms of fibroids are most commonly heavy bleeding. As you heard from Kim, she had a hemoglobin of 3, which really is almost incompatible with life. And I'm so glad that she's here today to share with us. But also you can have things such as pushing on the bladder, causing bladder leakage. You can have it disturbing sexual intercourse and causing pelvic pain because of the girth and the width of it, and also the weight. And then also abdominal distension, because as it grows a little bit bigger and out of your pelvis into the abdominal cavity, you start to see that growth and then have discomfort. So there are signs and symptoms that lead up to diagnosis of fibroids, but usually the most common symptom is going to be heavy bleeding. But again, as we've seen throughout the answers here, is that many times people will have heavy bleeding, but have not been notified that this is something that they need to discuss with their doctor. And so it's ignored for years. And so as the fibroid continues to grow, we really start to have two issues, the fibroid growth and then also the heavy bleeding that we have to discuss when they come in for a visit. So this is why it's so important that we have these discussions, so that people who are having heavier bleeding, it may not always be due to fibroids, but if it is, then we can kind of have a heads up and watch it if it is a smaller fibroid, and then watching it as it grows, but also dealing with the heavy bleeding, because that's impacting quality of life.
Great. Okay. Thank you. That's a perfect segue. So, Patty, can we talk about other things that might disrupt or might be out there under abnormal, whether it's uterine bleeding or pain, that women need to know about their diagnoses?
I think that two of the real big ones to talk about are endometriosis and polycystic ovarian syndrome. Endometriosis, like fibroids, can have a variable prognosis and course. Many women with fibroids have no symptoms at all. Believe it or not, the same can be said of endometriosis. Physiologically, what's happening with endometriosis is the very special cells that line the inside of the uterus are dispersed into the tubes around the ovaries or even distally to the intestinal organs. Those cells are going to respond every cycle to the systemic hormones by proliferating, growing, and bleeding. And that sets up an inflammation that results in painful, heavy periods. Well, many women with endometriosis don't know they have it and do well with no symptoms, but a lot of women, their lives are very interrupted, and potentially their fertility is interrupted by this process. On average, it takes 10 years for a woman to get a diagnosis of endometriosis. It may be diagnosed according to international guidelines by clinical presentation. It doesn't require laparoscopic surgery. And that's a conversation that I like to bring up with my patients early on. Patients read and patients wonder, and they don't necessarily express all of their concerns to the clinician. So early on, when I'm talking about painful, heavy periods, there are a lot of things that it may be, but we want to put on the list all the things that it may be and develop a plan, share the decisions but develop a plan of how we'll go about investigating this. Because treating a woman with endometriosis, and there's a variety of treatments, from simply hormonal contraception, the hormonal IUD, to what are called GnRH antagonists that sort of dial down the estrogen and thus dial down the inflammation, that can, as my patients say, give me my life back, these women back their lives. So it's something that it's great to have this conversation. Heavy, painful periods, it's on the list. There are a lot of reasons, but endometriosis is also on the list.
Thank you. And you touched on PCOS just by naming it, but can you tell us the difference and how that might show up in somebody's menstrual cycle?
So polycystic ovarian syndrome, I think it's a lot more complicated because it's a systemic disorder, endocrine disorder, that it begins in the uterus, where in a simplistic, and it's easy to get in less than precise when you try to change something complex into vernacular, but the ovaries are not listening well to the messages. And so instead of producing a nice healthy follicle with containing an egg every month, a lot of small follicles are produced. That makes sufficient estrogen, which also then gets transformed into androgens, which are testosterone-like molecules, but it doesn't develop enough of a mature follicle to actually ovulate. So the woman is left in an environment of high estrogens and high androgens and not ovulating, that the lining grows of the uterus, the lining of the uterus grows, but it doesn't get the ovulation and the signal to slough off and bleed. Women often will say any bleeding is a menstrual period, and that's something I'm really glad to include in our conversation, is that with PCOS, you will get bleeding, but it may be just a heavy lining sloughing a little bit without actually the full-blown sloughing of the uterus. I said it's systemic because that environment of high androgen, high estrogen also increases high insulin. So there are many systemic disorders that can be affiliated with PCOS. Cardiovascular disease is one of them. It is a lifelong condition that her periods present as either very, very infrequent or absent, or frequent spotting without a real period. The high androgen can cause symptoms of acne, facial hair growth. In some women, there's challenges with weight, but only about 50% of women worldwide with PCOS have overweight or obesity. So that's not all women, and very slender women can also have this. We need to keep her healthy by making sure, depending upon what her goals are, that she does regularly bleed and that uterine lining gets refreshed, if you will. If fertility is the goal, we need to help her ovulate, and health is everyone's goal. So we need to look at the systemic possibilities that can be associated with endometriosis. And exercise, I'm sorry, I said endometriosis again, PCOS. I have PCOS, so when I'm having this conversation with my patients, it's really easy to get personal and say, you might read the guidelines that we need to exercise 30 minutes a day. We belong to a special club and we need about an hour a day. We're going to be need to be a lot more active.
Interesting. And so we talked earlier about how long it takes to get diagnosed properly with fibroids and endometriosis. Is it the same for PCOS typically?
It can be. And I think that's a lot on us, the clinicians, because when we're talking about something as disruptive to a woman's life as any of these conditions, we sort of hate to go there. But I firmly believe we are doing a grave disservice to our patients if we're not honest about her body. It's her body. It's hers to make decisions with, and she needs to be fully informed. So that's why an early discussion will say, these are the things we want to look at.
Got it. Great. Thank you. So, Laura, let me ask you a question. So do you see different issues around menstrual health or menstrual concerns in women who have access to barriers to access of care. Oh my gosh, I can get this out. Barriers to access of care.
Absolutely. This is, you addressed me, is that right, Missy?
Yes, Laura, sorry.
Yeah, no, of course. Period Equity, my nonprofit, really focuses on menstruation. So I can answer with respect to that, but I think, access to products is not unlinked to access to education and healthcare. But Period Equity focuses on an issue commonly called period poverty now, which means that, the reality is that in the US, there are millions of people who menstruate who don't have access to the products they need to engage in their lives, to leave their homes, if they have homes, to go to school. And we are really pushing to rectify that by policy, by working with legislators around the country. And we are seeing that there is, that legislators are taking action in dozens of states now. There are laws relating to the free provision of products in schools and also in prisons and in shelters and so forth. New York City was the first government to provide free products in schools and to budget for them. And so the problem continues, and of course was made much worse through the pandemic and the economic fallout resulting from that, not least because the economics of the pandemic really disproportionately affected women.
Sure. So, and in your intro, you mentioned the class action suit, and then you're challenging the 30 remaining states. Where are you on that?
Well, actually, there are Newsbreak. There are actually probably 28 states, definitely 29 states left, because Vermont finally voted just last week to remove the tampon tax, and Maine is on the way as well. So we're down to 28 states, but they're lawyers sort of like myself, who are plaintiff side lawyers, kind of lead with rage and anger, and listening to you talk, there's so many enraging aspects of the neglect of women's health, especially the neglect of Black women's health, and communities that are targeted by environmental toxins and that affect our bodies, and the lack of research. But the tampon tax, as we refer to the sales tax on menstrual products, is sort of uniformly enraging. And I had noticed it as a law student years ago in New York and tried to file a lawsuit, but I was surprised, because I grew up with an OBGYN dad, that no one wanted to talk to me about menstruation. But finally in 2016, I was able to get the lawsuit filed, and New York State responded pretty much immediately. And finally, after decades of introducing a bill to remove the tax, they finally did it in 2016. So I have a team of about 50 pro bono lawyers who are helping to pursue other lawsuits. So we have a case in Michigan challenging their tax on tampons as unconstitutional, because it's a category of products that is unique to female biology. There, of course, we know that there are people who don't identify as women who menstruate, and there are is that right? So we have trans men who menstruate. There are non-binary people who menstruate, and there are people who call themselves women who don't menstruate. But under the law and the U.S. Constitution and state constitutions around the country, we think there's a very clear argument that taxing menstrual products, which is proxy for women, is a violation of the Equal Protection Clause.
Fascinating. And I love that you're attacking something that's so critical, right, to people having access to both products. But I'm also thinking about menstrual equity or period equity around knowledge and education, et cetera. And so just thinking about your populations, Jessica, maybe Laura or Patty, how's COVID-19 played a part in this issue? What do you see?
Yeah, that is a great question. I think initially, as we got into the pandemic, there were a lot of struggles for women as far as those who had issues and didn't know where to seek help, or because of the pandemic or what city they lived in, were unable to get to a provider's office. I do find that we were able to kind of change over into more of a telehealth format very quickly, and being able to adjust to what the pandemic brought to us. We were able to transition that into a way that patients were still able to access these care and resources. However, one of the things when you're thinking of disparities, is that not everyone actually has Wi-Fi access. And so those are one of the things that I found, as a provider through telehealth services, that we still have to find a way to communicate with areas and families and individuals that don't have that access. But in a time of a pandemic, this was an amazing way for us to still be able to take care of patients, whether we weren't able to do that in our office, and also offer alternatives to heavy bleeding that we couldn't fix through procedures and surgeries when our operating rooms were shut down as well. And so as we've transitioned, or we're transitioning out of, the depths of the pandemic and getting to a better place because of vaccination and being able to get back to what we were pre-COVID, I do find that we've had the ability to form better relationships with our patients, because we were in such a dire state of having to, again, address needs that were still there and still very relevant and pressing and acute, and finding ways to reach out to people and to patients. So it's kind of one of those things where it was one of the worst things that could have happened, but we have been able to transition through that phase and still being able to help many women.
Great. Laura, Patty, do you want to add anything to that?
Yeah, I agree completely with Jessica that the ability to do telehealth was critical to many of my patients. A woman who is working 2 very low-paying jobs, and her 3rd unpaid job, which is caring for a family, it's very difficult to get into a clinic. And so the ability to do telehealth was huge for our population to connect and be able to get care. And I think that out of all difficulties, there's growth and goodness. We need to, and it is very much a women's health issue, really push that we are able to retain the ability to care for our patients in this way. Telehealth is, now threatened by, we've got to go back to the old system where we're only going to pay the professional if the patient's in the room with them. At the same time, I did have some difficulty translating women's health completely to telehealth, because many of the conditions that we've talked about, you need to examine a patient. Your fibroids, you need an exam to see what is going on with her uterus. Can I feel it? Not always are symptomatic fibroids very super appreciable by a physical exam, but that's a very good first step to say, where do we go next without spending a lot of money? So we were able in our mobile van to actually do a one-way path where only I and the patient were in the little exam room together, and my scribe was in a different exam room on remote. I don't need a translator, but we were able to keep going and keep giving care, and that was very important.
That's great. I love that you got a mobile van. I want to address technology in a second, but Nakem and Laura, so just in general around menstrual equity, period equity, what do you think healthcare providers, community schools, other women can do to ensure access and improve this issue? Nakem, you want to start?
Sure. I think access to information, communities, patient advocates, schools, they need to come together to provide equitable access to information, because there is so much misinformation, there's so much conflicting information that it can be extremely daunting and overwhelming and discouraging, and you just don't know what to trust. So I think bringing accurate information to the communities that we are serving is a critical step to move the needle in a positive direction.
Laura, add to that.
I see that I need to, Cam, I would love to speak to you further about that, because the idea that information is not accessible is, again, putting on my lawyer's cap, is something that is so serious and damaging to people's health and well-being, and it should be something that we can think about regarding policy. I mean, Period Equity supports kindergarten through 12th grade comprehensive sex education, but given your very powerful story, there's also a question of, in a crisis, where can you turn? So I'm thinking this has been already just a great webinar for me to think further about these issues. But, in terms of what people can do right now about any of these issues is, and I know this from many, many conversations with state legislators, is there's so much opportunity in this area, because as we've been discussing, not many people will talk about menstruation and reproductive health. So just call your legislator, talk to people about things you care about. They don't know unless we speak to them. And one call can change policies in a city, a district, a state, even at the federal level. The work that's being done is in large part being initiated by kids in high school. For example, in New York City, at the beginning of the pandemic, when it was utter chaos and very scary, there were a lot of people who menstruate sitting home who had gotten free products through their schools, who couldn't leave the house. They didn't have products. And, we had a dire situation here. So the city council wasn't thinking about this enough. 2 high school students actually made it so that the products that had been stored in city schools were available for distribution at New York City meal hubs. And they pushed for that. They contacted the city council. So there is so much opportunity. If you see something that needs to be fixed, you're likely the first person to see it, and would be the first person to bring it up and change it. So I see that happening all over the country, all over the world, in fact, with great changes being made in other countries to provide free products and so forth. So it should continue, and maybe from this webinar, there will be more change from people listening.
Fantastic. And Patty mentioned technology earlier. Jessica and anyone else that wants to comment, how is technology impacting people's understanding, tracking, experiences around their cycles? Do your patients, are they tracking things? Are there things that you like? Jessica, do you want to start with that question?
I can go first.
Yeah, sorry.
Okay. So, as far as technology and the innovation of femtech, and also innovation in surgical procedures, when we look at, again, from the beginning of tracking periods and seeing if they're irregular, if they're too heavy, and again, looking at how that impacts quality of life. There are many apps that are devoted to allowing people to, 1, educate themselves, but also 2, track and trend their cycles, so then they can start to have the conversations on, again, how this is impacting their quality of life if it's abnormal. And then also looking at people who have a diagnosis of heavier periods, or again, have a normal period that's impacting their quality of life, and whether they have a diagnosis, whether it's through polyps, whether it's through fibroids. There's some technology that has been advanced from, again, when you look at why people are scared to have these discussions, having a hysterectomy. And many times there are people that think that the only solution might be a hysterectomy, and it doesn't always have to be that. And that's why working with the White Dress Project and allowing their population and their group who have had these experiences of being told that hysterectomy is the only answer, is that there are so many alternatives, whether that's through uterine artery embolization, whether that's through laparoscopic radiofrequency ablation of fibroids with the Assessa technique. There are things that people have not heard about. And the job as providers are to expose them to a breadth of options, whether that's through medical. We have now a new GnRH antagonist on the market, Orion, and that again is going to help decrease heavy bleeding that are caused by fibroids, into the technology that I discussed from procedural standpoint. And then again, looking at the education on how we can allow young girls into adolescence and young women really track their periods and cycles and feeling comfortable with discussing them. And again, bringing information to healthcare providers that are going to help them as a team discuss how they may have a better experience with their cycles, and also know what's normal versus abnormal.
Great. Thank you. We are going to be wrapping up in a minute, but I asked you at the beginning to think about like one thing that you would like the audience to take from this very, very rich conversation. And then I know it's there's a lot, but if we could just go across the top of my screen, and just what one nugget do you want the listeners to take away from today? Patty, go first.
Okay, I wanted to be last because I'm hoping my great colleagues here will pick up some of the other stuff. So much. But this is one, Laura, I'm gonna enlist you in your activism. Electronic medical records, to those of our audience, that's their computer charting. Do not include menstrual periods as one of the vital signs. You have a cute little block over here where you're talking about blood pressure and temperature, and you have to hunt all over the place for last menstrual period, if it's even included. So as more women see non-specialist primary care, our colleagues can do a great job, but it needs the information there to even start the conversation. So I want to see last menstrual period included as a vital sign.
Awesome. Great. Thank you. Nikia.
Yeah, coming from the patient perspective, I want more spaces like this, more safe spaces like this for us to be able to share our stories. Because as I mentioned before, there's so many of us who are suffering with these conditions in silence. So many of us who feel like we are the only ones going through this. So more conversations like this need to be had. We need to continue to amplify our voices, our experiences, so that we can disrupt the social norms and expectations, so that we can create those transformational changes and transformative changes and change the narrative around menstruation, around reproductive health issues, so that we don't have to suffer in silence any longer.
Fantastic. Laura, 1 minute.
Missy, I really appreciated you gave us the question yesterday so I could think about it. I have a very idiosyncratic thing to say that I've never said publicly, but talk to the men in your life. I have spoken to legislators around the country. I'll give you an example. Wyoming, one of the legislators who killed the tampon tax exemption bill this term said, well, if we exempt feminine hygiene products, then we should exempt male hygiene products. Not realizing that feminine hygiene products is a euphemism for a medical necessity. And, so I talk to the men. Men don't understand flow. They think that menstruation is like urination, like you just get to the toilet, you do your thing. And one of the things, I have a son, I just sometimes make up excuses to talk to him about things like, I was in a webinar the other day and I didn't realize that young men might not understand yada, yada, yada. So, or I read a book about, this that suggests that young men aren't taught this in school. So it will create an easier job for me down the road if, the sons you're raising really understand menstruation, keep those pads and tampons on the toilet, out in the bathroom so they can look at them. So that's my suggestion.
And that's perfect because Jessica has 2 little boys. So 1 minute, because I have to do a wrap at the end. What's the one thing you want the audience to take away?
I think what I want the audience to take away is something that I've learned throughout my practice as an OBGYN is that it really has to be an approach of both, yes, medical evidence, evidence-based medicine and what we know, but also considering lifestyle, considering different backgrounds, different cultures, ethnicities, and religions, and being able to take that in inclusively and look at how that can create the story and the narrative for the patient who's coming to see you, but also what I would offer. And so that's why with my new practice, Sanctum Med and Wellness, I really took into account the holistic and alternative ways that we can help women, whether it's with abnormal periods, fibroids, endometriosis, and incorporating the use of a pelvic physical therapist in our practice, a yoga studio, a meditation studio, and also acupuncture. So now, in addition to what I'm able to provide from what I've studied for so long, I wanted to build into the experience what patients can do outside of my office. And that's what I want them to know, is that there's so much more that we can incorporate through the knowledge of things that can help their lifestyle, but also through the diagnostic portion of their abnormal bleeding, and coming to a really good holistic treatment plan that can carry them throughout generations.
Okay. Thank you. And I love that, because we're all about everything below the belt working well together. Mm-hmm. So I've just been magically given 4 more minutes. So I have some pepper questions for the audience, because we did get a question about sex. So if I'm having, if I bleed a week before my period or so, is that okay? Should I be concerned? Patty?
So bleeding is triggered by the hormone changes that then trigger the communicators, which are prostaglandins, that tell the lining to slough off. And if you're spotting a week in advance, that can indicate that, one, it isn't a real period. Maybe there's just lining that's sloughing off and it's not being triggered by hormones. Two, your hormones are maybe not as stable as they should be right up until the time of your period. Or perhaps I'm going to add a fourth. Perhaps there's a prostaglandin issue going on that you're not giving that signal. And then the fourth could be something physical. Because if you have something like a fibroid changing the contour, the shape of the lining, you're going to have a less stable lining that could cause spotting. So while this can be a very normal things that happen as we are in the late reproductive stage, early perimenopause, and our hormones aren't as stable, it can also indicate something that needs further investigation.
Great. One last question, Jessica, super quickly. Can you get pregnant during your period? Having sex?
Can you repeat the question?
Sure. I'm having my period. If I have sex, do I need to use protection?
Or type it. Maybe it's my computer thing.
Oh, okay. Anybody else want to jump in on that one? Super basic question.
I think the answer is yes, because
okay.
Okay, perfect. That one
now I can hear you. What was the question?
The question is, can you?
The third time.
It's okay. We're about to wrap. I was just the question was, can you get sex during your? Can you get pregnant during your period? Should I use protection?
Yeah. Okay. Absolutely. Okay.
Good. I want to just put that out there, because we're out talking about these periods. So thank you everyone for this fantastic discussion. I think we could go on for another 2 hours, but on behalf of Healthy Women, thank you everyone in the audience and my panelists for joining us. We so appreciate you being here. Hope you will feel more informed about your period and anyone else's period that you might have interaction with. Thank you again to Myovant Science to their support of this webinar. And we invite you to visit the healthywomen.org site to register for the second All About Periods webinar, which is on June 9th at 7 p.m. Eastern Time, which will focus on removing shame, stigma, and barriers so that all people who menstruate can be confident and empowered in their discussions about their periods and any concerns or issues they may have. Thank you again so much for being here, and everybody on the webinar.
Thank you.